over to me to finish the presentations with the case studies, which neatly follow on from Steve's presentation and some of the quantitative elements of the study as well. So if I just bring back my slides, and hopefully that will be the right one. If I just do that. So that should be, everyone should see summary of case studies, hopefully. So
That's right,
I will,
Liz.
yeah.
Those,
So
thanks.
Steve's given a fantastic context on the kind of emerging program theories that came out of having a new look at the data that we had from the systematic review, which we then took and informed our questioning when we went into the SARC case studies as well. So first bit of this presentation, I'll talk to you about how we collected that data and some of the themes that emerged that actually reinforced the initial theories that we had as well. So we had 6 SARCs, and as Bryn said, we chose those as examples from of each cluster from the cluster analysis. We included the 2 SARCs that had psychologists attached to them as well, because we felt that was important to include them as well. So the sample, the people who participated, were 3 groups. They were the staff who worked, so core teams who worked within a SARC, people representing partner agencies, so that would be local mental health, local psychological therapy services, community mental health services, etc., and substance use, and most importantly, the people who actually use the SARCs, as we call the survivors as well. So we got NHS ethics for this. You'll note the date. We got ethics in late 2019, and obviously we know what comes next in 2020. So I'll tell you a little bit about that in a minute. We actually had to delay our data collection from March 2020 because all NHS research was halted to allow for COVID research. But in addition, some of the conditions under which things were operating in that very, very high intensity change of all services, including how GP practices were run, mental health services, how the SARCs were running, it would be almost impossible, even if we had been allowed to continue to start collecting it, and it wouldn't have been appropriate anyway. So there was a big gap where we kind of did more work, desk-based work, and then moved the data collection to later as well. So we got informed consent, and the staff focus groups were undertaken by our research team using online Microsoft Teams video meetings, which actually worked really well, and we could record them in Teams, and then we could get a download, which was then transcribed verbatim as well. Transcripts were analysed in vivo, coded against the initial program theories, which Steve has just been through, whilst data collection was ongoing, so that as we could continue to collect data, we could do it in a more iterative process and use what we were learning to ask new questions as well. So the coding framework was overall designed to map the journey through the SARC. That was our overall structure, is like pre-SARC, during the SARC, post-SARC, to capture those contexts and mechanisms that Steve has highlighted from the literature as well. We met regularly throughout the analysis process, online obviously, to discuss emerging theories and consider additional questions. So we undertook 26 interviews and focus groups with staff, which was 31 people, and 17 interviews and focus groups with staff and partner agencies. We undertook 12 service user interviews. Of those approached from the prevalence study, which I'll talk about in the second half of this, we got about a fifth agreed to be interviewed. We would like to have interviewed more, but given the challenge of online interviews and the COVID pandemic and lockdowns, actually we did as best we could with that recruitment as well. So I'll just run through some of the themes that emerge from the case studies, and these are triangulated against everybody's contributions to those qualitative interviews as well. So back to this idea about SARCs, people being aware of SARCs, all the survivors that we spoke to didn't have any, apart from one person, didn't have any prior knowledge of SARCs. And they described things like the police told them about it, or they'd Googled it with a friend and then discovered that there was a local SARC. So increasing awareness and access is an issue, something that staff talked to us about. Like they would like to do more awareness raising, but sometimes there just wasn't the space and time to do those additional kind of activities as well. The staff also talked a lot about the need to do more outreach work into specific underserved groups. Again, this is something that came out of the literature that Steve talked about, is if you look at the profile of who gets to a SARC, actually there's a whole lot of other groups of people who they never see. And we need to kind of think about how we can help that as well. Mental health expertise is we've got a lot of data about this. There are limited mental health backgrounds. The staff talked about their own experiences and their own lack of confidence in working around mental health. It often leads to a lack of clarity about what to do in a crisis, and they do from time to time, and it's totally understandable, have people in very acute distress who really do need some further input urgently from mental health as well. So there's an example here. I've included a quote. I was with a patient nearly 8 hours because I didn't feel it was safe to let her go, but we didn't have a safety plan because nobody would see the patient. It was just like a hot potato until eventually we could get her into a car, take her to A&E for her own safety. So it's a last resort really to take that person. So I've just got a pop-up. Let me just, oh my goodness, hang on. Please get rid of that. Sorry. There was varied practice on how psychological well-being / mental health was assessed in drugs and alcohol. But what people talked about was how useful it was if there was a psychologist located in the SARC. It was very useful to the wider team as well. Oops, hang on, let me just scroll through. Okay, so during the SARC experience, the thing that really struck us was the narrative around how clear it was that every single SARC was providing almost naturally a trauma-informed approach and interactions at every step, from literally the initial phone calls to the meet and greet at the door, right through to the forensic exam and in follow-up as well. And there's so much, I mean, I've got so many kind of quotes in the report about how warm people felt about the SARC staff and how it was a real kind of oasis in a pretty bleak moment in their life as well. So I think that's really important to say. And this idea that people just had a sense of control, even though what you've been through and you didn't have control when the assault took place, you still have control in the aftermath. And I think that was really important. The forensic exam itself was quite a lot of input around how the exam was conducted and the atmosphere. And Steve talked about the context and the values and attitudes of the people conducting the forensic exam and the support that people had and how it was very trauma informed. People felt very in control, was also really important for not just for their physical health and obviously getting the forensic evidence, but also just for their mental well-being as well. And in terms of aftercare themes, so where there was in-house therapies and or support, survivors had this experience, thought it was really, really helpful. They just felt that in-house or bespoke support, people just got what they'd been through without them needing to explain and not feeling judged. So they just know how to word things, as one of the quotes. They felt seen as an individual, they felt listened to, and they felt believed, and that being believed came up a lot. The follow-up by SARC was really varied. There was varied practice of follow-up after that initial visit. Some SARCs had a policy of a follow-up call about 6 weeks later, or even offered an appointment. Others were, and this is to do with resources really, were only able to signpost or refer to other agencies, and that was the limit of their involvement. ISVAs were often associated with the SARCs and would that's the Independent Sexual Violence Advisor, which supports people if they're going through the court proceedings, criminal proceedings. um, were involved at that stage. Where follow-up calls happened, the survivors really valued it, but also the SARC staff said it was actually quite helpful for them to do the follow-up, because they would then check on whether some referral they'd done had actually happened, or whether there was a new need that has emerged that they could maybe help signpost them to different help as well. In terms of access to external agencies, this is really mixed. Really mixed. So some places people were already familiar with mental health services and kind of had a service support anyway. Other people talked to us about experiencing a referral, but then a long waiting list. And this, again, you've got to remember, this is in the COVID pandemic, and things were really tricky in terms of what was on offer, and a lot of it was online as well. There was often only option of very short-term generic support, and some people who'd experienced support following the SARC felt that some of the mental health professionals that they'd encountered didn't quite understand this specific issues around sexual violence. Or they've had a lack of understanding more broadly as well. There was one person said they had talking therapies on the NHS. They felt, I just didn't like her. She felt like she was judging me, and I just left. Other services they send you to have nothing to do with what you've been through. It's like they're speaking to you. You think, hang on a minute, you haven't a clue what you're talking about. This isn't how I felt. This isn't how it happened. You're judging me. So again, this sense of people not really getting it in a generic, so primary care psychological therapy service. But actually, how important it is to get help. As someone said, I don't think, to be honest, I'd be here today. I wouldn't be how I am today. I can go out now on my own and feel comfortable. Before the services we've deleted, I couldn't go out at all. SARC staff talked about the challenges knowing what services to refer to. People just didn't have a good understanding of the different routes into different services and what their remits were as well. And I think sometimes they acknowledge that their own lack of mental health expertise meant they didn't quite understand the landscape, and therefore that could get in the way of the referrals as well. And just to say, the other thing about external agencies, the external agencies we talked about their challenges and felt that they didn't actually know what the SARC did, or that it even existed in their local area. So there's a real mismatch between the SARC services and mental health and substance use services as well. Quite a lot of mental health and substance use agencies said they didn't routinely talk about sexual assault with people who came through their care as well, which again is an area to definitely needs addressing. So in some from the case studies, there was limited general knowledge of the SARC services from external agencies and also survivors, and what happens there, which can also lead to anxiety about going there. Well, once people knew what was going to happen, they felt that anxiety drop, but potentially I could see that might put some people off if they haven't got a kind of sense of what happens. I think SARCs do a great job. We've got plenty of evidence to support that they do a fantastic job at reducing the risk of re-traumatization, operating in a trauma-informed way, myth busting, especially being able to bust internalized rape myths. It was my fault. There's shame, etc., etc. There's countless examples where they clearly take that on the head and help people reconstruct what happened to them in a way that busts those misconceptions as well, which is great. There is a lack of mental health expertise, and this is creating issues not just with assessment, also referrals to other agencies. Having someone in the team, as say a psychologist, for example, help them identify needs and a plan of action, and also supported staff in considering the impact of the work on their own mental well-being. So staff obviously working in a SARC, it's and I know a lot of you also work in sexual violence services will know this. It's there's a vicarious impact on yourself and your own well-being. You're seeing a kind of day in, day out, a kind of sort of very traumatic stories, distress, and so it's important. The psychologist was also able to help people understand their own responses and think about how they can support their own mental well-being and prevent burnout as well. There is not a smooth pathway to trauma therapy and other support. And I know where we had a question in the chat earlier about referral and what happens afterwards. Although this was qualitative and only 12 people, certainly we didn't see much evidence at this point about a particularly smooth process of people getting into services. But of course, we need to do some longer term follow up to really look at that as well.